క్వశ్చన్ సార్. హలో,
ఇప్పుడు వస్తుందమ్మా కరెక్ట్ గా.
ఓకే సార్, వినిపిస్తుందా సార్?
అంటే ఆల్రెడీ So good evening all. Gowthami, it's audible.
Yes, sir.
Welcome back for the CBD sessions connected by Andhra Hospitals. It's the 7th one. And today we are going to discuss about an interesting topic, DKA management with different scenarios. It will be done by Dr. Gowthami. She is our junior consultant in the Andhra Hospital. She did her MD from Bagalkot, Karnataka. And later on she finished her PSU fellowship from our hospital itself. And currently she joined with us as a junior consultant. And without wasting much time, Gowthami, you can take over.
Yes, sir. Thank you, sir. So good evening, everyone. So we'll start with the case scenario. So here is a 13-year-old child brought to emergency department by parents with complaints of increased urination, increased thirst, and increased appetite for past 7 to 8 days, swelling and redness and pain over the bridge of the nose from 3 days, and hurried breathing, pain abdomen, and vomitings for 2 days. So this is the initial impression on arrival to here. So what is your assessment after this initial impression? So the child is appearance is drowsy, color wise there are pale peripheries, and child has tachypnea. So on initial impression. So what intervention you will take at this point of level? Anyone? So definitely child is in unstable life-threatening condition. So at this point, we will start the child on oxygen. So on primary assessment, airway is maintained. Breathing wise, there is tachypnea, but air entry is good and maintaining sats at room air. Circulation wise, there is tachycardia with feeble pulses, peripheral pulses, and cold peripheries with prolonged CRT. BP is okay, normal, low normal, and there is a polyuria, and child is drowsy with a GCS of around 13/15. So what is your impression here at primary assessment level? Anyone? So we identified that child's airway is maintainable, breathing wise there is tachypnea or mild respiratory distress, and child is in compensated shock. So here our intervention is we started a fluid bolus for this child. So I started 10 ml per kg fluid bolus. Then comes your secondary assessment. Here there is no significant past history for this child. On examination, there is cellulitis over the bridge of the nose and signs of dehydration present, and there is epigastric tenderness. So what are the possible DDs with this presentation? So definitely with the history of polyuria, polydipsia, and now tachypnea, epigastric pain, and vomitings, our first possible DD would be diabetic ketoacidosis. With that cellulitis, like possible sepsis, and other possible DDs could be acute pancreatitis with a history of acute pain, abdomen, vomitings, dehydration. But polyuria and polydipsia, polyphagia won't explain it. And yours, it can be sepsis with shock. Only against this child has polyuria, and another is diabetes insipidus. But child has other features like polyphagia, epigastric pain, vomitings, etc. So the most probable diagnosis is here is DKA. So what workup would to be planned for this child? As we are suspecting diabetic ketoacidosis, our workup should include first blood sugar, then comes your blood gas to see for pH and bicarbonate and PCO2 levels, and urine ketones, and CBC and CRP to rule out infection, and electrolytes and renal function tests. And as the child has cellulitis, we sent a swab from that local site for culture sensitivity, and we also sent blood culture and sensitivity and HbA1c. So these are the lab values. So what is your impression with the previous presentation and this lab values? What is the interpretation about this child? So there is definitely severe metabolic acidosis with urine ketones positive and high blood sugars. So this confirms a diagnosis of DKA with elevated total counts. Though it is not significant for infection, there is a high CRP, which suggests there is infection along with the history and the symptoms, signs. And there is an elevated urea and creatinine. So my interpretation here, is a child is in DKA with sepsis and probable AKI. So we managed the child with the initial 20 ml per kg fluid boluses, after which perfusion normalized. Then we started on replacement fluids, and after 1 hour we started the child on insulin infusion at a rate of 0.1 unit per kg per hour, and we started IV antibiotics. So how much fluid boluses to be given? If a child presents in shock, how will you titrate fluids here? Anyone? Anyone to answer this question? If a child presents in shock with suspected DKA, how will you start fluid boluses? And if there is only features of dehydration, how much fluid bolus to give, whether to give or not?
If patient is in shock, no need to detect fluid boluses.
Okay, very good.
And take 10% dehydration as correction.
Hmm.
And start maintenance fluid for 48 hours correction.
Okay, that's good. So first we'll talk about bolus. Here we'll start with the 10 ml per kg bolus. Until the perfusion gets normalized or the hypotension gets corrected, we can continue fluid boluses. Once shocks get corrected, we can change to requirement fluids. And if the child is not in shock and there are only signs of dehydration, we can give a initial fluid bolus of 10 ml per kg over 30 minutes. This is according to BSPED guidelines, and this bolus should be subtracted from your replacement fluid. So what type of fluid should be given for resuscitation?
Normal saline.
Yes, we can use isotonic crystalloids, and most commonly available for is normal.
There is a question in the chat box.
Yes, sir. If shock is not correcting and it is fluid responsive, we can continue fluids. Always reassessment after each bolus, and if it is fluid responsive, then we can try another fluid bolus. If it is not responsive to fluids, then we should reconsider the type of shock and decide about inotropes.
Yeah, same thing only. But if you have boarding pulses, DK it's hypovolemic shock. But you have add-on sepsis, you can have septic shock as well. So don't miss the septic. Yeah, septic shock component. If you have boarding pulses like that, you can go for NORAD. And myocarditis and cardiac failure, cardiogenic shock is very rare in DKA. Mostly fluids with an add-on tinge of vasopressors. NORAD or vasopressin is the choice in add-on sepsis. But mostly they will respond to fluid. And if you're needing more fluids, think that it is not purely hypovolemic. there's an add-on sepsis component as well, distributive component. So you have to cover with vasopressors. NORAD is the first choice. Continue.
So definitely type of fluid would be isotonic crystalloids. Like most commonly available is normal saline. We can also use plasma light. So how to calculate requirement fluid? So this is again based on calculating deficit and maintenance fluids. Deficit will calculate according to severity of dehydration, and maintenance fluid will calculate by Holiday-Segar formula. Whether to include the initial fluid bolus while calculating requirement fluid. Whether we should include or not. Any answers? So if the child is in shock and we are giving fluid for shock correction like resuscitation, so we need not correct that fluid bolus. We need not subtract that fluid bolus while calculating requirement fluid. And if you are giving fluid for dehydration correction, you should subtract that fluid bolus from while calculating requirement fluid. So again, how will you grade severity of DKA? Again, depending upon the blood gas, like severity of metabolic acidosis. So choice of fluid will be NS or balanced crystalloids, and requirement fluid calculated by some adding up deficit and maintenance, and deficit calculated based on severity of decay and maintenance according to Holiday-Segar formula. And this we already discussed. If child is in shock, no need to subtract that initial bolus. If child is not in shock, if you are giving for dehydration correction, you should subtract. So our child is 40 kg weight, so we calculated his replacement fluid, and it came to around 162 ml per hour. So this is a table showing the severity of decay based on pH bicarbonate, and how we'll calculate dehydration percentage according to severity of decay. So this child, we know the line of management, how to manage, but what all to monitor, what we'll monitor clinically in this child, and what lab parameters we should regularly monitor. So clinical state, like clinical monitoring, bedside monitoring should include hourly neurological status monitoring your vital signs, and input output, maintaining an input output chart, and monitoring your ECG. And lab parameters include hourly glucose monitoring, second to fourth hourly or blood gas monitoring depending upon the requirement, and monitoring your electrolytes and RFTs frequently, and monitoring blood or urine ketones. So we have corrected the shock, shifted the child to PICU, started insulin infusion after 1 hour, and after 2 hours of insulin infusion, the glucose values are still high despite infusion rate of 0.1 units per kg per hour. What could be the possible causes here?
Inappropriate doses, organic cannula issues.
Yes, definitely inappropriate dosing or incorrect dosing of while calculating insulin. Yes, if your cannula might be blocked, it could be one reason. What could be other reasons? So other reasons could be your improperly stored insulin or inappropriate priming of tubings, or fluid, if you are not giving adequate fluid, or if there is any miscalculation in fluid while calculating fluids. So here it could be dosage problem or catheter related issues or storage issues or inadequate priming of the tubing or any inadequate fluid resuscitation. So here we started insulin from new IV line. There is no response. We change it to new vial. which is appropriately primed. Like we primed the tubings appropriately, and now glucose level started decreasing. So after 1 to 2 hours, we noticed that sugars dropping very fastly from around more than 500 to within 3-4 hours, it started coming down by 125 mg per dl. So whether to decrease insulin or what we should do at this level?
Change the type of fluid.
And decrease insulin. 0.05.
Decreasing insulin is not a right option. We should always change to dextrose containing fluids. So what is the reason for like not to decrease insulin? Ideally, we are not supposed to decrease insulin infusion rate. The best thing to do is change to dextrose containing fluids. And the reason here is we are giving insulin to correct the ketosis, like to decrease the ketones, but not for correcting your hyperglycemias. So ideal thing is to change to dextrose containing fluids. And whenever in any DKHL, we are starting on insulin infusion and fluids, it is ideal to start insulin infusion and fluids from the same IV cannula, so that we can avoid hypoglycemias and hyperglycemias. So after 8 hours of admission, gradually child started becoming drowsy again and GCS is falling. So what are the possible causes here and how do you manage?
Cerebral edema.
Yes, cerebral edema is a common cause. And other thing to rule out is any hypoglycemias. How do you manage cerebral edema?
Mannitol.
Yes, you use a 3% NS or mannitol and take other neuroprotective measures like head end elevation, head in midline position, prevent all noxious stimuli, if any hyperthermia, fever spikes are there, aggressively treat fever spikes.
Yeah.
And maintaining adequate MAPS.
Euglycemia.
Yes, euglycemia. But here our target is ketosis rather than euglycemia, like to decrease the ketone levels. So you slowly go down on decreasing sugar levels. So how do you, so we also take a CT brain to rule out any thrombosis or hemorrhage or infarct. So what are the risk factors for cerebral edema in DKA children?
Large volume of fluid policies.
Yes, inadvertent large volume or rapid fluid resuscitation is one of the cause. What are the other causes?
Insulin boluses.
Yes, giving insulin boluses would precipitate cerebral edema. And starting insulin very rapidly, like before even 1 hour, even before completing your fluid resuscitation, initial boluses, starting insulin before first 1 hour. Other causes are if child has hypocapnia, which is more than adjusting for a degree of estrosis, like profound hypocapnia at the time of presentation, high blood urea at the time of presentation, and giving bicarb correction for acidosis. All these can also precipitate cerebral edema. So what is corrected sodium?
Gowthami, just 1 minute.
Sir.
I want to ask all, what are the, you have seen so many risk factors. So what are all they telling to you? What is the major risk factor for cerebral edema? Single line, major risk factor for cerebral edema. Everything is pointing towards one thing.
Osmolarity.
Exactly. So you should not alter the serum osmolarity too rapidly. So you have to go very slowly. The main crux in the management of DKA is you should not alter the physiology, whatever is the physiology, you should not alter it too rapidly. Whether it is your bicarbonate, which is causing rapid correction of acidosis, which will alter the PCO2 levels in the brain, or your rapid fluid resuscitation, which is going to decrease your serum osmolality rapidly. So everything is dependent on osmolality and your CO2 levels. The CO2 level alteration will cause more blood flow to the brain, and osmolality change will cause shift of fluids. So make sure that you are not doing these two things too rapidly. So one thing is altering your pH too rapidly, altering your osmolality too rapidly. So the main thing we need to try to avoid in decay management. So that all these are the risk factors which will alter your CO2 levels too rapidly, or your osmolality levels too rapidly. So try to make sure that you are not dealing with too rapid alterations in anything. So go slowly and steady. That is going to win in decay. Continue, Gowthami.
So here in this child, there is a rapid corrected sodium rise, which indicates there is rapid correction of fluids, and there is PCOT is very low, like it is more than correct, like there is hypocapnia even after adjusting to the metabolic acidosis. So these two factors we identified in this child. So if there is this is interpretation of too rapid rise or fall in corrected sodium. If it is there is too rapid rise, then it indicates excessive fluid loss or insufficient replacement. If there is a rapid fall, it indicates a rapid replacement of fluids. So as a child ECS is falling, we decided to electively intubate the child. So what are the peri-intubation precautions to be taken here? So child is in metabolic acidosis, he has tachypnea, and this child, definitely this is a physiologically difficult airway. So what all peri-intubation precautions to be taken here?
We should correct.
Correct? Hello? So for this child has tachypnea to compensate for his metabolic acidosis. So we should maintain the respiratory rate at the same physiological rates. And whenever we give sedation for this child, there will be depression of the respiration transiently, which will cause increase in the PCO2, which will further worsen the pH. And drop in pH, any small drop in pH may precipitate cardiac arrest. And sedation will also depress the sympathetic activity, and it will decrease the BP. It will cause hypotension and it will lead to cardiac arrest. So here, what are precautions to be taken? Pre-oxygenating the child, choosing a right sedative. Here we consider ketamine with neuromuscular blocker, and blood pressure monitoring, and if required to start an inotrope support, and hyperventilation before and after intubation to match the patient rate, to avoid any drop in, like, to avoid any increase in the PCO2 and further fall in pH. So what are the initial ventilator settings? So your rate should be equal to your physiological respiratory rate, and tidal volumes around 8 ml per kg, and your target PCO2 should be equal to your pre-intubation CO2.
Gowthami, just don't avoid confusion, don't call it the physiological rate. It is the rate of the patient.
Yes, sir.
Physiological rate is for the age, and for that situation, what the child is breathing at, you need to consider the same rate. That's what just you are telling same only, but for avoid confusion.
Yes, sir. Pre-intubation respiratory rate. A bagging or ventilator setting should be equivalent to the rate at which a child is breathing before the time of intubation. So despite improving sugars, child has persistent metabolic acidosis. So what could be the possible causes here? So first it could be due to inadequate insulin infusion to cut down the ketones or inadequate fluid resuscitation. And other possibilities could be, commonly it could be a coexisting sepsis. Sepsis can cause persistent metabolic acidosis. And other causes can be your hyperchloremic metabolic acidosis because of the large volumes of resuscitating fluid containing chloride. Hyperchloremic metabolic acidosis can be there, which is causing your persistent metabolic acidosis. And other possible cause could be your acute kidney injury. So here's these are the lab values, electrolytes of this child. So there is a sodium of 148, chloride 118, bicarb is 12, anion gap is 18, bicarbonate 12, urine ketones 1 plus, and anion gap by bicarbonate ratio is 0.5. So despite your urine ketones coming down, there is a persistent metabolic acidosis, which is not explained by, which is not due to decay. So the cause for persistent metabolic acidosis here is, one is hyperchloremia and another is AKA. Here a delta ratio or a change anion gap by change in bicarbonate ratio of less than 1, it indicates mixed metabolic acidosis. So here it is due to hyperchloremia and acute kidney injury. So in hyperchloremic metabolic acidosis, as already discussed, due to large volumes of chloride containing fluids resuscitation, and it will manifest as persistent metabolic acidosis. And in this child, despite decreasing sugars and urine ketones, there is persistent metabolic acidosis, and blooduria and serum creatinine are in increasing trend. And gradually there is a decrease in the urine output. So what are the risk factors associated with acute kidney injury in DKA? Hyperchloremic, here is a question, how to avoid hyperchloremic metabolic acidosis. Hyperchloremic metabolic acidosis is a transient thing which will resolve over a period of time, short duration of time. So
we can try balanced crystalloids. So there are available plasmalite A, that are things which is available, which will contain low chloride. The NS, you can see the chloride level is 154, and in a balanced crystalloids like plasmalite A, it was around 90. So if you can try that, but sodium is normal isotonic fluid. It's isotonic fluid, but with the low chloride. So that fluid, if you start that fluid at the initial stage itself, you can avoid hyperchloremic metabolic acidosis. But once if you able to correct ketosis part with only with hyperchloremic acidosis, as Gowthami told, it will resolve. So no need to worry. For that alone, you no need to continue insulin. So the only problem with balanced crystalloids is the cost. For NS to balanced crystalloid, the cost is almost 4 to 5 times. So depending on that, if you're able to, ferrets are affordable, you can able to procure balanced crystalloids. The initial choice is directly go to balanced crystalloids rather than NS. But if you don't have the supply, you want to continue NS, please go ahead with that. But when you're treating for acidosis, just look whether you're treating for persistent ketones production, DKA acidosis, or it is hyperchloremic acidosis. DKA acidosis, you have to consume insulin. For hyperchloremic acidosis, you can cut down the insulin and you can switch over to regular insulins, and you can cut down the DNS part to NS part to half NS, like that for hyperchloremia management. That's once the child is out of ketosis.
yes. So dehydration is one of the risk factor for AKA, and severe metabolic acidosis at the time of presentation. Hypophosphatemia induces rhabdomyolysis, and usually AKA is most prevalent in adolescent age groups. So whenever there is a persistent metabolic acidosis, despite correction of your ketones, we should look for hypophosphatemia. So for the above child, the serum phosphorus is low, 0.8 mg, and there is an elevation of CPK. So how to manage AKA in this child? Cutting down the fluids. And what is the RRT of choice in this child? CRRT or peritoneal dialysis are RRT of choice in this child, and there is no role for hemodialysis or SLED because any rapid shift in osmolarity will further worsen the cerebral edema. So for this child, we initially started peritoneal dialysis, and with PD, the acidosis got corrected. But serum creatinine, it initially transiently got corrected, but it again started shooting up. So as the child sensorium is improved, we considered hemodialysis and creatinine started decreasing. So these are the serial pH, bicarbonate, and urea creatinine levels of this child. So initially there is severe metabolic acidosis with a creatinine of 1.8, and it is still persistent even after 12 hours. There is a persistent metabolic acidosis, not explained by not due to decay per se. So started the child on PD, there is an improvement in pH, and creatinine initially reduced, but it increased again. So after considering hemodialysis, creatinine started decreasing and urine output improved. So for this child, we changed to subcutaneous insulin by day 3 and extubated after 72 hours. And hemodialysis continued, and child creatinine is in decreasing trend, and urine output is increasing. And after 7 cycles of hemodialysis, child creatinine became normal and discharged home on subcutaneous insulin. So what are the take-home messages here? Fluid resuscitation is the key in decay management. Giving appropriate type of fluid at appropriate time is very important. And never decrease insulin infusion for fall of sugars. And insulin is for ketones, not for sugars. And don't forget to check phosphate levels. Acidosis correction is getting delayed by 24 hours. And closely monitor corrected sodium and anion gap. Look for any alternate causes for persistent acidosis. If insulin delivery is correct and sugars are under control. And always look for underlying infection and treat it.
Thank you, Gowthami. Very well presented. If anyone has any questions, we'll take up the questions. No questions. I think everyone understood very well, Gowthami. Gowthami, there's a question.
So what are the indications of bicarbonate therapy? Bicarbonate is not indicated in acidosis correction in DKA. Even if there is a persistent metabolic acidosis, and if you are suspecting other causes, If your acidosis is not due to your ketoacidosis, if you're suspecting other causes, like in this child, there is acute kidney injury, and by that time her ketones became negative. So it is purely because of AKA. In that child, we consider bicarbonate therapy. Can we treat fever in DKA with
Got
antibiotics?
1 minute.
Yes.
And one more indication is hyperkalemia. When you have hyperkalemia, even during treatment of DKA, that is the only indication where you have to rush for the bicarb.
Yes, sir.
So initial presentation itself having AKA with the hyperkalemia, then you should definitely go ahead and treat with bicarb. No other choice. And like Gowthami told, the initial management, there's no role for bicarb, and later on management, where suspecting hyperchloremic metabolic acidosis, and the child pH is not much improving, and you make sure that your sugars, everything is under control, and ketosis is already under control, then you can try bicarb. Go ahead, Gowthami.
There is another question in chat box here. Can we treat fever in DKA with antibiotics? So if there is a fever, first we'll try to localize any like a site of infection, any clues of a coexisting infection. If we feel it is clinically also investigations where is also not because of bacterial, like no need of antibiotics, we need not consider. If any suspicion of infection, like keep a low threshold for antibiotics. In this child, CRP is high. Total counts will be elevated in DKA, inflammatory response. So we started because there is a clinical evidence of sepsis, cellulitis is there, and CRP is high. There is another question, sir. Mannitol and 3% NS, which is better in normotensive child with cerebral edema with DKA? So 3% NS is always a osmotherapy of choice when compared to mannitol, and in DKA we always prefer 3% NS. There are some studies showing that mannitol may further worsen the diuresis. So we always consider 3% NS.
And if the child had AKA, mannitol is out of question. So we cannot give mannitol.
There are two more questions, sir. Preferred regimen of subcutaneous insulin after correction of DKA. So preferred regimen is initially transiently we change to titrate the insulin dose. Initially we will change to rapid acting insulin with 3 doses before meals. Once you came to titrate the insulin, how much insulin requirement is there, we can shift to basal bolus regime, which includes a long acting insulin. Like we divided the insulin requirement into 40% and 60%. So 40% of insulin will give long acting at night time, and remaining 60% in divided doses will give rapidly acting insulin. But problem with this insulin regime is child need to take 3-4 pricks per day, and if the child is school going, it is difficult to take at school. So for school going children, or if it is difficult to give 3-4 pricks per day, we can switch on to split mix regime. So always we can titrate that regimen according to the patient, according to the individual child.
The initial dose for insulin regularly will follow is 0.8 to 1 unit per kg per day. The starting insulin dose, then we titrate up based on up and down based on the initial figures.
Yes, sir. And another question, sir. If bicarbonate is 2, pH is 6.9, and if child is on insulin of 0.1 unit per kg, and child is not improving even after 24 hours, and biochemically can we start bicarb? So if your pH is not responding, If your bicarb values are not improving, pH is not improving, definitely you should look into the causes for your failure of like not responding by check for any inadequate insulin dosage, improper improper priming, check for cannulas, like keep correcting until you achieve the what is the final like mistake where it is going on.
Actually, we need more information for this question. So what are the sugar values? So whether sugars are coming down or not, and what are the ketone status? So the two important questions we need to have before that before the scenario. If sugars are coming down very nicely, then there's no problem with insulin. So the answer, the sugars are not coming down. Then there's a major problem is with insulin delivery. There's no other goal. So sometimes in adolescents, they'll have insulin resistance. Your 0.1 unit per kg per hour will not be sufficient for them. So they can have some like kind of picture of type 2 diabetes also. Especially in adolescent people, we have faced this, and where they have an element of insulin resistance, only 0.1 is not sufficient. So there you can go up. Before that, you had to rule out all the other things like cannula issues, priming issue, vial issue. You can change to a new vial, new tubings, new cannula. And if you have done all these things and still your sugars are not coming down, then you definitely need to go up on the insulin dose. So this is what I learned from an endocrinologist who suggested that for adolescent people where your sugars are not coming down despite all the measures you have taken for the corrective measures, they have a slight insulin resistance, then you have to go up on the dose of insulin. So before that, but make sure that you have corrected everything, like a slide on the corrective measures. So keep everything checked before you are stepping up on the insulin. So that slide is very important, how to correct that insulin delivery. So everyone has to deal that slide very, I think that's a more take home messages from this talk. How to correct insulin delivery. Yeah, this slide. So if you're not able to get down the sugars, try to check whether you have dealt all these things.
If you are facing such scenario, what I learned here is we start insulin infusion and fluid from the same line. So that will always prevent that inadvertent hypoglycemias and hyperglycemias.
Any more questions? If any questions are there, you can post to the group as well in the WhatsApp group. So we'll try to answer there also. And so it's a very good presentation, Gowthami. Very well done and very well interactive session. And thanks for the audience also for the interaction. And I hope because of the time constraints, we're going to close this session. And if you have any doubts, please put in the WhatsApp group. There's so many intensivists and other things are there. So they can answer with their experiences. They can answer. So not only from our hospital, it's there from other hospitals as well. So if you have any doubts, please keep posting in the group so that everyone can learn. Thank you all. Thank you.
Thank you, sir. Thank you all.